we are moving on to part 2 of my presentation, where I will talk about other directed violence. So it's really important that as future clinicians, we know that we're going to likely encounter violence in the workplace, and therefore we're going to need to know how to identify and treat victims and perpetrators of violence. We're also going to need to understand how to protect ourselves and our coworkers from victimization when violent persons who are receiving treatment are voluntarily or court-ordered for comorbid psychiatric issues. We're also going to need to recognize vertical and horizontal violence in the workplace and help prevent it from occurring. So just a general overview of what violence is. It's defined as the exertion of physical force to abuse or injure somebody. It occurs by use of profanity, destructive and furious force, infringement on the rights of others, and distortion. Types of violence can include assault, which can be defined as slapping, beating, rape, homicide, threat and or the use of firearms, knives, bombs, or other weapons. Battery is defined as unwanted physical contact or threat to inflict harm, such as biting, kicking, slapping, hitting, or spitting. Sexual assault is defined as fondling, rape, words or conduct of a sexual nature that cause alarm, emotional distress, or annoyance. Verbal assault are threats that are written. They can be verbal or communicated via body language. And then we have horizontal and vertical violence. Horizontal violence is violence that's perpetrated against someone of an equal rank. For example, another nurse to another nurse. And vertical violence is violence that's perpetrated against someone of different ranks. For example, like a supervisor to an employee or vice versa. So types of violence that we're likely going to encounter is a variety. Could be battery, could be child abuse, bullying, emotional abuse, intimate partner violence, murder, rape, property destruction, stalking, and workplace violence. Clinicians occasionally might encounter human trafficking victims or perpetrators, survivors of war, survivors of mass violence. We may also encounter refugees that come from areas where the rape of men or women were used as a form of war. So during our risk assessment, to assess for aggression or violence, during the mental status exam, you'll want to take note that obviously if somebody's making direct statements of wanting to hurt somebody, are they paranoid? Are they having command hallucinations to tell them to hurt somebody, or that voices are telling them that somebody else wants to hurt them, like the persecutory hallucinations. Of course, psychosis, thought insertion, agitation, the fear of being hurt, if they have PTSD symptoms, and substance abuse. Social environment, patient history, you want to take note as to whether or not they had witnessed abuse as a child, were they sexually or physically abused as a child, have they engaged in prior violent acts, have they had any military training, have they endured any recent trauma, are they currently being victimized in their situation. Excuse me, that was my timer. Any severe psychosocial stressors, a really bad divorce, their cultural background, if they came from a more patriarchal, male-dominated culture, there's a higher risk for partner violence. Are they unemployed? Personality aspects, do they have narcissistic traits? Are they antisocial or borderline personality disordered? Organic brain disease, there are some medical conditions here. You'll want to watch for delirium, advanced age and or terminal illness in a partner or the patient. There's some fairly grim statistics here on intimate partner violence. So between about 23 to 37% of women have suffered from intimate partner violence at some point in their lives, in a study that was done recently in 133 countries. Minority immigrant women of Asian descent have an incidence of 41 to 60% of intimate partner violence. It's the most prevalent type of violence in the world, and the most common abuser is the woman's spouse. Risk factors for male perpetrators, they tend to be people who have low education level, younger age, unmarried, low verbal intelligence quotient, they're unemployed, or they're employed with receiving welfare benefits, lower income, they may be abusing substances, be under a lot of financial stress, and they could have a history of violence towards other men as well. Femicide is a term I found in our book. They define it as when intimate partner violence leads to death for the female. Minority women are less likely to seek help for this type of violence, more so than Caucasian women. And victims are more likely to experience abuse when they try to leave, of course, leave their partner. When they fail to meet the expectations of the abuser, the abused disagrees with the abuser, or the abuser is using substances. Some child abuse statistics and information here. 1 in 5 girls has been sexually abused during childhood, so that statistic's quite high. When intimate partner violence is disclosed, parenting styles and methods of child discipline is relevant, so that's something that you're going to want to look at. Kids who are abused, they'll have signs of physical neglect and abuse, such as inappropriate or inadequate clothing for the weather, poor physical condition, poor hygiene, unexplained injuries, lack of lunch at school, bruising on the face or neck, or injuries that are just uncommon in childhood. They tend to have anxiety disorders or behavioral problems. The kids do. And a lot of them develop conduct disorders, and the acting out can raise suspicion for abuse as well. Abused children are vulnerable to lower achievement of education, physical and health problems, poor peer and social relationships, earlier onset of mental health problems, higher risk for substance abuse, earlier sexual activity, and conduct disorders that lead to juvenile delinquency and adult criminality. So it's crucial that we look for those risk factors, and that early detection is important. So bullying is another form of violence. It can include physical, psychological, and intimidation acts that are aimed to socially isolate and control individuals from others. Often produces feelings of low self-worth for the child, depression, and mental health problems. Girls tend to internalize the bullying, boys externalize by acting out. Kids who are bullied at an early age, they've again experienced mental health problems. Typically, if they've been bullied prior to 2nd grade, or it started as early as 2nd grade, they're more likely to have mental problems by the time they get to 5th grade, and then often have difficulties with transitioning during that adolescence period. And you'll see more acting out or more withdrawn. Predictor of suicidal behavior in bullies and victims as well, so doesn't look good for either the aggressor or the victim. Elder abuse is another issue. The incidence is about 7 to 10%. There's a higher rate of mistreatment among those who have low social supports. neglect, psychological abuse, and financial abuse are the most prevalent form among elderly. Immigrants, especially with poor English, and those who come from cultures where it's impolite to complain, are the most vulnerable. Men and women both are found equally to be perpetrators of elderly abuse. Female spouse perpetrators tend to emotionally abuse or physically neglect their spouse, while male spouse perpetrators tend to physically or sexually abuse their spouse. They often have time leaving their abuser, of course, if they're medically disabled, or women who've never worked outside of the home. So rape and human trafficking is a big issue as well in our country and worldwide. Well, let's see here. For rape, the lifetime prevalence is about 18 to 30% in the U.S. Asian women, the prevalence is much higher, 68%. 15 out of 16 assailants typically never spend a day in jail. 2 out of 3 assailants were actually known to the victim. And there's some data that says that this didn't reduce the amount of injuries to the victim, whether or not the person knew them. 44% of victims were younger than 18, which is really sad. It's sad anyways, but sexual assault is considered to be one of the most severe traumas. And unfortunately, a lot of victims experience a lot of negative reactions from family and friends, which can really worsen their recovery and cause severe PTSD. Men, of course, are unlikely to report sexual assault. And women who live in rural areas experience confidentiality issues when they report the rape to police scanners and emergency communications. And if they access services for support, and it can cause the entire community to be aware of who the assailant is. Some people don't believe the person, the victim, and this can cause victim blaming. And then human trafficking statistics. Here, there's approximately 200,000 current victims in the U.S., which is mind-blowing, mind-boggling to think about. Worldwide estimate of victims is 45.8 million, so it's a really, really huge problem. Those who are vulnerable, most vulnerable, are undocumented laborers, teen runaways, people of low socioeconomic status and poverty. The victims are often moved around frequently to prevent detection, kept by force and coercion for financial gain, and we really, for assistance, their immediate needs are shelter, safety, clothing, food, and medical attention, and comprehensive psychiatric services are really important for victims. Violence toward healthcare professionals. The third leading cause of occupational injury fatality in the U.S. It's the second leading cause of death of women at work. A lot of nurses they're at high risk for abuse by patients and visitors. They often experience horizontal and vertical violence. And, of course, violence from patients who are acutely agitated. This could be due to long wait times, intoxication and withdrawal. They have significant illnesses, mental health crises, and physical issues. Patient violence toward healthcare providers. This can include stalking, which is physically following the clinician, giving unwanted or threatening phone calls, voicemails, emails, or texts, driving by their home, coming to the office without an appointment, using GPS technology to locate the clinician without his or her knowledge, which is pretty scary. Internet slander is also an issue regarding services they received. A lot of times they'll post on the internet, negative feedback or negative experiences that, may not necessarily be true. Frivolous lawsuits, complaints to licensure boards, vandalism, trespassing. Sometimes they display knowledge of the clinician's personal life, like the name of a spouse or their children. And victims of this type of violence can suffer from PTSD and anxiety months after the incidents. So safety for healthcare providers, obviously make sure there's no weapons on the premises, never be in the office alone with an agitated patient, or see a patient after hours. When meeting with psychotic patients, make sure there's a family member or caseworker present at each meeting, and ensure emergency procedures are in place to protect yourself and everyone from a violent patient, friend, or family member. So populations most vulnerable to violence include migrant populations, as I mentioned already, healthcare providers, psychiatric clinicians, seriously mentally ill persons. It might include anyone who's not getting along with the patient at home or in their neighborhood, or someone the patient might be targeting. Mental health clinicians, of course. Criminal justice personnel are also vulnerable. Child protection workers. And I found a really grim statistic. The World Health Organization reported that 41,000 children younger than 15 are murdered annually. So that's, again, keeping in mind that intimate partner violence or children who might be vulnerable when you're working with patients. If the patient has children and they're unsafe, or they might be abused, that's reportable. Risk factors for becoming a victim: teenage runaways, really young or old age, people who live in communities with street violence and high crime, people with physical disabilities, people who have a history of childhood abuse, sexual abuse, and or intimate partner violence, substance abuse, mental illness, LGBT community, again, as I've mentioned already, immigrant or minority status, and homelessness. Those who are at risk for perpetrating violence, if there's substance abuse, psychotic disorders, someone who has intermittent explosive disorder, delirium, dementia, adjustment disorders with disturbance of conduct, mood disorders, delusional disorders, ADHD, conduct disorders and antisocial personality disorder, low IQ, history of a head injury or chemical exposures, history of traumatic childhood experiences, and biological problems such as neuroendocrine issues, genetic history, and hereditary factors can cause people to perpetrate violence. So when we're doing our assessment, the first thing is to make sure to rule out medical reasons prior to addressing the psychiatric issues of aggression and agitation. For children, maybe they ingested something that's causing the agitation or aggression. Has the patient had an adverse reaction to a medication? Have they been abusing recreational or using prescription drugs, or did they have an overdose? Are there any drug interactions, especially in the elderly, that can cause aggression? Also, you want to consider doing a urine toxicology to rule out substance abuse. And there's some questionnaires that you can use to assess for violence risk and aggression. And you also want to make sure to inquire about intimate partner violence, child abuse, history of being a victim or a perpetrator, and inquire about elderly abuse. So, medication management of acute agitation in the clinical setting. You're going to want to, like I said already, exclude medical conditions, focus on rapid stabilization, avoid coercion, treat the agitation in the least restrictive manner, keep that therapeutic alliance in mind, and then, of course, focusing on that aftercare and discharge plan. So treatment's going to involve oral and intramuscular injections. We need to offer the patient oral medications first before considering injections, which would be the last resort, and encourage them to ask for as-needed medications and so they can be able to recognize when they start feeling more anxious or agitated or when they get more impulsive. Benzodiazepines and the typical atypical antipsychotics are treatment for the short-term agitation. Typically, Ativan 2 mg IM is favorable, tolerable, safe, and often effective. Haldol is often used as well, either 2.5 mg to 10 mg PO or IM, and up to 40 mg per daily dose, which is combined with the benzo, as I mentioned, and then that'll help improve sedation, and then as well as the anticholinergic to counteract the antipsychotic to decrease the risk for dystonia or EPS side effects. Oral disintegrating formulations are available as well. Zyprexa or olanzapine varies from 5 to 20 milligrams PO, and Risperdal 1 milligram to 3 milligrams can reduce agitation and provide sedation. The Zydis formulation of the Zyprexa and Risperdal M-tabs are really difficult to cheek, so they're really ideal to use in that short acute stage. Geodon is also available as an injectable form, 10 to 20 milligrams, and Zyprexa as well in the injectable form, 2.5 to 10 milligrams. So make sure we follow up on side effects after the administration of any medications given for acute agitation. You're going to want to monitor for acute dystonia. This can include the locking of the jaw, severe drooling, tongue thickening, inability to speak or swallow, oculogyric crisis, or deviation of the eyes in any direction, or the torticollis. And if any of this, you see any signs of this, we want to do Benadryl 50 to 100 milligrams IM immediately. And then you'll also do for the next 48 to 72 hours to prevent reoccurrence, Benadryl or trihexyphenidyl PO medications. Neuroleptic malignant syndrome, you're also going to want to watch for. It's very life-threatening. The patient will immediately need to be hospitalized in intensive care if this is actually occurring. It can manifest as a change in mental state, rigidity, hyperthermia, labile blood pressures, tachycardia, and profuse diaphoresis. Dysphagia and mutism may occur. An easy way to remember it is that presents or looks like the flu, but the person can't talk to you. And a hallmark sign is elevated creatinine kinase. Elevated levels more than 1,000 to as high as 100,000 have been found. Leukocytosis can also occur with a left shift, electrolyte abnormalities, mild elevation of alkaline phosphatase, lactate dehydrogenase, and liver transamines. Low serum iron also is present or could be present, and even though it's really rare, it's more likely to occur if there's a rapid increase in the dose of the neuroleptic, if they're getting multiple or large doses, if they're agitated, if they have dehydration, or they've had a prior episode of NMS, not neuroleptic malignant syndrome. Also, of course, look for any allergies or anaphylactic reaction. You'll see that pretty quick if it's anaphylaxis. QT interval prolongation. There's a few medications here that have documented cases where that's actually occurred, where it led to the torsade. I cannot say that. I'm so sorry. Cardiac death. Risk is really high with the QT interval prolongation. The oh gosh, I'm not even going to try to say that. That medication is the highest risk for sudden cardiac death. The risk is 2 times higher in men and 10 times higher in ages 70 to 74. I haven't really seen that medication used that much at all since I worked in mental health for 5 years. There's a list here of medications that can cause this too, and I put the link there. And interestingly enough, escitalopram and citalopram also can cause the QT prolongation. Then we have the serotonin syndrome that can occur with neuroleptics and or antidepressants, and it's a medical emergency. The person's going to have could have altered mental status, confusion, anxiety, dysphoria, irritability, or agitation. Autonomic dysfunction might include labile blood pressures, diaphoresis, dilated pupils, shivering, hypersalivation, and tachycardia. Neurological symptoms include the myoclonus, ataxia, hyperreflexia, muscle rigidity and tremor, diarrhea, incontinence, and nausea or vomiting. So maintenance interventions for aggression, for medication-wise, anti-epileptic drugs and mood stabilizers work really well. Depakote and phenytoin works best for adults with cluster B personality disorders and men with impulsive aggression in outpatient settings. The oxcarbazepine helps for verbal or object aggression in adult outpatients. Antidepressants are good for aggression that's worsening. Fluoxetine can be very helpful in addition to CBT, group therapy, etc. And lithium can also deter aggression if it's a manic type of aggression or due to mania. So general considerations when deciding which medications to prescribe for aggression. You want to really have a good grasp on what their target symptoms are that you want to manage. And obviously diagnosis is key. Medical conditions, consider their living situation, their likelihood of adherence to taking the medication, access to lab or clinic to get lab draws, attend appointments, cost or convenience. Medications may be better where they don't require blood draws for patients who are afraid of the blood draws or don't have access to clinic. Use antidepressants with caution, as this can exacerbate violence or agitation, which I thought was interesting to Ensure women of childbearing years to use birth control or have pregnancy tests prior to initiating psychotropic medications too. So children, risperidone and Abilify are effective, but both have the metabolic side effects. Kids typically have more weight gain, reduced ability. They have a reduced ability to eliminate medications and are prone to the hepatotoxicity. So we want to monitor them closely, and they're at higher risk than adults for the akathisia and dyskinesias. Elderly, they're more likely to experience hypotension, and sudden deaths can occur with antipsychotics. Limited effectiveness of antipsychotics for Alzheimer's, so that's always a tricky issue, is the dementia-related aggression. That's kind of controversial. Keep in mind there is one known case where in an elderly woman in which they used Seroquel, and she developed neuroleptic malignant syndrome, and she actually died by the use of that Seroquel. Make sure to note any drug interactions and the risk to benefit ratio as well of the medications you're choosing, and serum concentration of antidepressants may be higher. Medications with narrow therapeutic index range require frequent lab monitoring. Typical lithium, you gotta watch for the thyroid function, and then the electrolyte disturbance of the sodium intake, sodium, potassium, and make sure to get a baseline EKG. Clozapine is also one that we want to monitor the drug level closely and watch for the neutrophil count. Other side effects to monitor for is extrapyramidal symptoms with akathisia risk, with the antidepressants and antipsychotics. Movement disorders can occur at any time during treatment with antipsychotics, but they're more likely to occur early on in treatment. With dose increases or discontinuation, some medications you have to be careful and make sure to taper them slowly. So blood dyscrasias are also a possibility. Anticonvulsant hypersensitivity syndrome, SIADH, hyponatremia, acidosis, weight gain, hyperglycemia, metabolic syndrome, cardiac events, elevated prolactin levels, hypothyroidism, sexual dysfunction, and renal problems. Other measures to address aggression, maybe they have excessive caffeine intake that can cause increase in agitation or irritability. If they're withdrawing from caffeine, they might be irritable. They might be more anxious if they've had a lot of caffeine. They should try to limit refined foods and sugar. Omega-3 fatty acids and vitamin D is good too. They should try to increase their activity level. Yoga, running, walking, CBT and DBT is helpful, as well as maintaining milieu management. Allow a place for the patient to ventilate their anger or frustration, either in their room or quiet room to scream. If they're on an inpatient unit, mindfulness is also helpful, deep breathing, and trauma therapies for PTSD. EMDR is very helpful. And legal implications, always remember your legal obligation to warn victims of potential violence. Remember, we are mandated reporters and responsible to report if a person or child is at imminent risk for harm. And of course, be aware of your state laws regarding reporting abuse and legal processes. So here are the discussion questions, and I have these posted in the discussion board for you to read take a closer look there. And here are my references. And that concludes my presentation. Thank you.